Thank you, Mr. Speaker. When I began, I said that the Black maternal health crisis was not just about statistics, because behind every statistic is a mom who didn't make it to raise her child. I want to tell one such story now of Kira Johnson. Kira was already a mom to Langston and Charles Jr., wife to Charles. She was a PhD student at Pepperdine. And on April 12th, 2016, she was admitted to Cedars-Sinai Hospital at about 12:30 p.m. for a routine C-section delivery. At 2:33, she gave birth to her son, Langston. At 3 p.m., Kira was out of the operating room and was taken to a post-anesthesia care unit. And shortly before 5 p.m., blood-tinged urine was seen in Kira's Foley catheter. By 5:24 p.m., Kira's Foley catheter was draining bright red blood. Her doctor was made aware of Kira's situation, but it wasn't until 6:44 p.m. that a surgical emergency CT scan was ordered, but it was ultimately not performed. At 11:42 p.m., two physicians were at Kira's bedside, and one performed an ultrasound that found expanding hematoma and now free fluid. They recommended taking Kira to surgery to identify the source of the bleeding, but her physician, Dr. Name, who was also at the bedside at this time, wished to continue expectant management at this time. By 12:30 a.m., as Kira's condition continued to rapidly decline, her husband, Charles, pleaded for help. And Kira was finally taken to surgery about 12:30 a.m. on April 13th, 2016, 10 hours from the time when the family initially realized that something was wrong. At 2:22 a.m. during surgery, Kira was found to have 3 liters of blood in her abdomen and did not survive the blood loss. She was pronounced dead at 2:22 a.m. on April 13th, 2016, and the autopsy stated that the cause of death was due to hemorrhagic shock due to acute hemoperitoneum or massive internal bleeding post-C-section. Now, Cedars-Sinai Hospital signed an agreement, reached a historic settlement agreement with the Biden administration's HHS Office for Civil Rights. It entered into a resolution agreement on January 6, 2025, to take significant steps towards ensuring that no other family has to go through what Kira's did. The agreement required Cedars-Sinai to provide training on the hospital's obstetric hemorrhage management policy, create a pain management protocol for assessing and managing acute pain for birthing patients, update guidelines for trial of labor after C-section delivery, and continue to track the vaginal birth after C-section success rate. Administer an online bias reporting tool to document incidents of bias or suspected bias experienced by patients and the public, require staff to complete respectful care trainings, and develop and implement a program to provide doula resources and patients. A week later, President Trump signed his executive order banning diversity, equity, and inclusion practices. And because the settlement agreement promotes diversity and equity efforts and is grounded in healthcare non-discrimination protections, it is under risk. That's just one example of how the actions of the Trump administration last year is making the maternal health crisis, particularly for Black women, worse. I spent a lot of time as a member of the Senate of Virginia working on addressing Black maternal health as a member of the Joint Commission on Healthcare. And through our maternal mortality review teams, we were able to track and identify the differences between rates of death of white women, Black women, Indigenous women, and we found the reasons were different. Using national data sets through the Pregnant Risk Assessment Monitoring System, or PRAMS, which is an entire CDC team that monitors risks associated with pregnancy, we were able to determine that, at least in Virginia, Black women were more likely to die due to cardiovascular issues, an underlying health issue, before they got pregnant, whereas white women were more likely to die from suicide or drug overdose related to mental health issues. With those different data sets and understanding these differences, we were able to focus on policies that address the underlying root causes to eliminate Black maternal deaths for both Black and white women. And we began to see some progress. But again, the very team managing PRAMs and the data sets we were using to identify the root causes and the differences is now gone. The staff that oversaw the HHS Health Resources and Services Administration, which is a national maternal mental health hotline that can help field calls from new moms seeking mental health support, was cut. DOGE canceled funding to several Black maternal health projects. The Trump administration defunded research at Morehouse's School of Medicine on how to improve the health of Black pregnant and postpartum women, cut research on how stress influences racial and ethnic differences in maternal health outcomes for women with hypertensive disorders, and it cut studies on uterine fibroids, which disproportionately impact Black women. And it wasn't just HHS and CDC that removed data sets. There was data from the Census Bureau, the EPA, as well as the CDC that were detailing racial and ethnic data broken out by other factors that helped show some of the risk factors that led to differences in these underlying health outcomes and maternal health outcomes. Without these data sets, how are we going to track the causes, which change over time, and put policies in place to address the causes, and then track to see if those policies are working? And so it's very frustrating, again, as someone who nearly bled to death giving birth to my daughter, that we're not able to address these, and there doesn't seem to be an urgency, as Congresswoman Moore said, to address these underlying causes. The Medicaid cuts are going to make it worse. Medicaid finances about 65% of births from Black mothers, and these cuts are only going to increase the disparity in maternal mortality rates and lead to more deaths as millions of Americans lose their health insurance. This health insurance is relied upon by pregnant women across the country for prenatal visits, but ultrasounds, screenings for conditions such as preeclampsia, gestational diabetes, postpartum depression, but it also helps them get annual physicals that will identify cardiovascular issues. The President's DEI executive order also makes it more difficult to address bias in medicine. We've seen medical schools that taught students for decades that Black people can tolerate more pain, which led to tragic outcomes. And we have heard story after story after story of women in the hospital who said after giving birth, something's wrong. And they were ignored, and something was wrong. This disparity also occurs in other health, but again, I want to connect the correlation between heart health and maternal health. I remember being at a conference discussing the disparity in heart health, where a woman said she had her first heart attack after she became a mother. After giving birth, and she went home and she felt odd, and the more she thought about it, she's like, I think I'm having a heart attack. And she went to the emergency room, and the doctor said, no, you're not having a heart attack. You don't meet the risk factors. You're only 36 years old. You've never had a history of heart disease. Come back later. You know, you're not having a heart attack. She went home. She was having a heart attack. Unfortunately, she was able to get back to the hospital before she died. That's just one example. We've heard many, whether you're Serena Williams or Kira Johnson, where you know something's wrong, and yet the hospital, the doctors don't listen. That happens more and more to Black women. We've got to do something about it. So you heard today that the Black Maternal Health Caucus has put forward, under Rep. Underwood and Rep. Adams' leadership, the Momnibus Act. So what is that? It's a comprehensive package of 14 individual bills that will make critical investments in the social determinants of health that influence maternal health outcomes, like housing, transportation, nutrition, pollution. It'll extend WIC eligibility in the postpartum and breastfeeding periods. It'll provide funding to community-based organizations working to improve maternal health outcomes and promote equity. Increase funding for programs to improve maternal health care for veterans. Grow and diversify the perinatal workforce to ensure that every mom in America receives maternal health care and support from people they trust. Improve data collection processes and quality measures to better understand the causes of maternal health crisis in the United States and inform solutions to address it. Support moms with maternal mental health conditions and substance abuse disorders. Improve maternal health care and support for incarcerated moms. Invest in digital tools to improve maternal health outcomes in underserved areas, particularly rural. Promote innovative payment models to incentivize high-quality maternal care and non-clinical support during and after pregnancy. Invest in federal programs to address maternal and infant health risks during public health emergencies. Invest in community-based initiatives to reduce levels and exposure to climate change-related risks for moms and babies. Promote maternal vaccinations to protect the health of moms and babies. And make critical investments in research to reduce preventable causes of maternal deaths and improve health care for women before, during, and after pregnancy. This bill has 205 House co-sponsors and has been endorsed by 313 national organizations across a variety of issues. We hope that this will be the year, this 10th anniversary of Black Maternal Health Month will be the year we make progress, because we've already regressed and we can't afford to wait a moment longer. And I'd be remiss if I didn't reiterate yet again the importance of reproductive freedom. When a woman is told, as I was, if you get pregnant again, you could die, the decision from that point on, or really the decision at any point, of when, whether, and how to get pregnant should be with her and her partner and who she wants to have part of the decision, and not her government. The decision of what type of contraception to get access to should be hers and her doctor's. Because when you reach a certain age, some contraception is more risky, and yet the forms that are best for you, some politicians, not doctors, politicians, don't think you should have access to. And these abortion bans that have exceptions for the life of the mother, we've seen, particularly in Texas and in Georgia, that has led to tragedies where women show up in the midst of a miscarriage, in the midst of bleeding out, and the hospital has to wonder, are they close enough so that we can provide the care that they need, or do we have to wait until they're septic? Well, once they're septic, it's probably too late. These are things that we've been warning about before the Supreme Court overturned Roe versus Wade. And unfortunately, our warnings have come true. We've got to think through the impact of when politicians make decisions about health care and not physicians and patients. It can have tragic results. And so the Congressional Black Caucus and the Black Maternal Health Caucus will continue to fight for Black moms everywhere. We will continue to fight so that we don't need Black Maternal Health Week anymore. We will continue to fight, rooted in justice and joy, so that no other mother has to worry when they get the best news if it's going to end tragically. We are here to make sure that it doesn't. And with that, Mr. Speaker, I yield back.